Next, we will go with the next topic, which is the enigma of CNLDO decoded. We have an invited speaker, Dr. Sonam Nisar, who is a consultant oculoplastic surgeon at the Department of Oculoplasty at Shankar Nethralaya, Chennai. Over to you.
Thank you, Anju, for that introduction. And at the outset, I'd like to thank the entire team, organizing team of KSOS, as well as Dr. Anju for inviting me here. And my topic for today is enigma of CNLDO. I cannot start this topic without paying my respects to the gurus of Guru, Dr. Badrinath. I may have not known him as well as a lot of the other fellows, but I'm very proud and I feel privileged to be a part of his legacy at Shankar Nethralaya. So my dear friend here, Dr. Soumya, has already spoken very well in detail regarding the anatomy of lacrimal drainage system. So what is CNLDO? Congenital nasolacrimal duct obstruction. It is one of the most common causes of pediatric epiphora and accounts for about 26% of all disorders of lacrimal system. The most common incidence is higher, the incidence is higher in Down's baby. It is as high as 22 to 36%, and that is one thing that we must check while we are assessing Down's children. So CNLDO, to simplify it, is divided into two parts. That is a simple CNLDO and a complex CNLDO. A simple CNLDO just has a membranous obstruction at the valve of Hasner at the level of NLDO. Whereas complex CNLDOs may have a lot of syndromic associations, may have associated atonic sac, annullage ducts, buried probe syndrome, and maldevelopment of NLD as well. So, what do you expect when a patient is coming to you with congenital nasolacrimal duct obstruction? Do you see immediate watering discharge? No. The tear secretion starts only approximately between 4 to 6 weeks after the child is born. That is approximately 42 days after the child is born. So you will start seeing symptoms as early as 1 month. So what are the signs and symptoms? Basically, most of the patients that you see come in with their informants. They'll be parents or caregivers. And they'll say they start seeing watering, discharge around 1 to 1.5 months of age. So you'll see watering, discharge, as you see here in this child. You see an increased tearful meniscus height. You see matting of the lashes. You see very subtle periocular excoriation. And you see a mucoid discharge which is there. Now, you may or may not see a swelling along the lacrimal sac area, and in case of recurrent acute dacryocystitis, you might even see an associated lacrimal fistula, or you might see a CNLDO along with a congenital lacrimal fistula as well. So it is very important when you see a child with watering or epiphora to distinguish CNLDO from other causes of tearing. It could be punctal atresia, stenosis, conjunctivitis, corneal foreign body, and very notorious congenital glaucoma. So it is very important to do a thorough ophthalmic examination, avert your eyelids, check the corneal diameter, check the IOP. One of my favorite tests in pediatric age group, because children never cooperate for anything, is a FDDT. So you can see, as you see here in the picture, it's a very simple test. You just put 1 drop of fluorescent dye right into the cul-de-sac and wait for 5 minutes. When the child is playfoot, not when the child is crying, otherwise we get false results. So when you see this at the end of 5 minutes, you see that there is still a dye which is there, right here, compared to the other eye where there is no dye. That will indicate that there is some level of obstruction. It is very, very important when you get like 1.5 year children to look at the puncta, because many a times these patients might have one puncta which is missing, because that will help us assess and plan our management, in fact probing much better. Another very standard, very basic in OPD test is Roplas. So what is Roplas? Regurgitation on pressure over lacrimal sac area. So this is just a pictorial documentation to tell you how exactly should we do Roplas. Here you see the first line, it indicates the medial canthal tendon. And then you see one line which is going around the inferior medial curve of the orbital rim. So just start from down, from the inferior medial angle, go up towards the MCT and press posteriorly. That is the correct way of doing Roplas. In children, prefer to use a little finger compared to your index finger because they're small, so little finger is much more efficient when you want to do this. Besides that, a lot of studies have also associated CNLDO with anisometropic amblyopia as high as 10 to 12%. So it is very, very essential when you see a 6-month and older child to do a cycloplegic refraction in order to look for any refractive errors as well. Now, there is an entity which all of us must be aware of, and that is congenital dacryocele, also known as an amniotocele, because of the fluid that is collected within the sac is the amniotic fluid. Now, this is something that, yes, you will see right from birth. In fact, many scans can actually diagnose this in utero as well. So as you see here, this is a 5-day-old baby who presented with a swelling along the lacrimal sac area. It is generally has a bluish hue. And this you see the patient on day 7 of birth. You can see how inflamed and infected this has become. You can also see that there is mucopurulent discharge here. So amniotic fluid, which is present in a dacryocele, is actually a very good medium for the bacteria. Hence, these patients have recurrent acute dacryocystitis episodes, and that can be very dangerous. Hence, this is one of the indications for an early probing syringing. So here you can see, we took up this patient on day 8 after starting a small dose of antibiotics based on the age. The baby was hardly 4 kgs, and we did just under topical anesthesia, we did a probing under endoscopic guidance. I would like to emphasize this, that all probings that you do should be done under endoscopic guidance, because there are many nasal pathologies that can be coexisting with an NLD obstruction. So as you see here, you can see this is an endoscopic picture of this child. You see this is the inferior turbinate that I'm showing with my arrow. But what do you see here, right below the inferior turbinate? It's a huge intranasal cyst which can be associated with congenital dacryoceles. And this should be marsupialized when you're doing a probing. You would have ordinarily missed this if you were not doing an endoscopic guided probing. Also, this is an ultrasound picture of this child in utero. I am very thankful that we had this picture, and this had already been picked up by the sonologist when the child was actually 36 weeks old. So it helped us plan the treatment much better. Now, congenital dacryocystitis can just be like an an adult dacryocystitis. It can have stages from a mucocele, then a lacrimal abscess, spontaneous drainage causing an external fistula. You can have associated preseptal cellulitis, orbital cellulitis, and very rarely orbital abscess. But yes, that can happen in a neglected case of CNLDO. So this was a 2-year-old child who presented to us with complaints of watering since birth. And you can see here, you can see all telltale signs of an orbital cellulitis. Imaging showed a picture of an orbital abscess after drainage on day 5. Look at how the child is. So these things are something that must be picked up early, and these are few indications of doing an imaging in a case of CNLDO. Now, 80 to 90% of these children actually have a spontaneous remission. So we must technically wait for at least 12 to 18 months before we plan any surgical intervention. Now, what do we have to do? You know, if there is a block, there's going to be tears which is going to be collected in the lacrimal sac. Now, any potential dead space is a potential thing for an infection. So most importantly, in order to prevent any acute infection, we must keep on emptying that dead space. That can be done by Krigler's massage. Now, this Krigler's massage goes back 100 years. It was first described by Krigler's in 1923. And it's a very simple thing. I will show it to you how to do that. And we'll talk about management as and when we proceed. So this is a simple video of how to do Krigler's massage in a child. Take your little finger, go all the way up till the lacrimal sac, drain the lacrimal sac, and then press the lacrimal sac. You'll see all the collection coming out from the puncta, and then press it all along the lateral wall of the nose, where your NLD is. It's a very basic anatomical way of doing the massage, emptying the sacs, causing a positive pressure and a negative pressure, in the hope that the membranous block will get opened fast. Now, you may ask, how many times to do this massage? You can advise this massage 3 to 4 times a day, 15 strokes each time. So technically around 45 to 60 times. Now, you don't want the skin to get really rough, so we advise normally the children to use the parents to use an antibiotic ointment on the little finger and then do the massage. So if Krigler's massage fails and the child is coming to you around 12 to 15 months of age, you can proceed with probing and syringing under endoscopic guidance. But there are few indications of early probing, and that one must be well aware of. Now, what do you see here in this picture? You see nice congenital cataract here. You also see there is matting of lashes, there is discharge. So a few indications of early probing syringing is recurrent acute dacryocystitis, a dacryocystocele, any impending intraocular surgeries, ROP surgeries, retina surgeries, or cataract surgeries. Now, this is a quick, I'll just run through this in the interest of time. So normally we do probing only from the upper upper puncta. Why? Because there can be some instances where you can have a punctal split, you can have damage to the canaliculus, and you know that 80 to 90% of the drainage is normally from the lower canalicular system. So that is why in order to preserve that, we normally do the syringing and the probing from the upper puncta. You always must do a syringing after you finish a successful probing from the upper puncta, because that will tell you from the lower puncta also whether it's patent or not. You just go directly hit the bone, then you rotate 90 degrees, you do a spring test, and then you visualize the probe under endoscopic guidance. Okay, can I take 2 more minutes? Okay, so here you can see the probe right at the level of the inferior meatus, and then we do a syringing to look for the successful outcome. I'm just going to rush to this because I've already mentioned about the importance of endoscopic guidance. You can have a buried probe syndrome where you might have a metal on metal touch, but you still have the probe which is not coming out into the inferior meatus. That is one of the indications why you should look into endoscopically. Now, if your probing fails, you might want to do a intubation, which could be bicanalicular, monocanalicular, and you might ask me when to remove the intubation tube. That would be at 4 to 6 weeks after intubation. Nowadays, for simple probing, we prefer monocanalicular intubation, but if you have complex, then you can choose bicanalicular intubation sets. This is very common in children, and this is called as a spaghetti syndrome because the tube keeps popping out from the caruncle area. Balloon dactylioplasty also has been recommended if your probing syringing fails. The success rates are very variable, and I don't have any personal experience with that. But if everything fails, then we resort finally to a DCR, especially in case of atonic sac and where a probing intubation or dactylioplasty has failed. Now you can choose to do an external endoscopic or even a transcanalicular DCR in a pediatric, in a child. So do not hesitate. Only thing is you need to use a pediatric endoscope if you're planning to do a pediatric endo DCR. And there are a few things that you must group. Maybe that is beyond the scope of this class. But yeah, that's all. And these are the main few FAQs that people normally ask: the role of antibiotics, when to intervene, type of tube intubation, and when to intervene. I hope I've answered most of these questions, and this is a very good review on congenital NLDO, which by Aldo et al., which everybody can go back and refer to. Thank you so much. And I would like to actually mention this case scenario. It is a case of Tessius tube with A. rhinea. And the child actually had a cataract in the other eye, which is only seeing eye. So now how do you do? What do you do in such scenarios? What we did was we went ahead and we did an external DCR and made the opening into the opposite septum so that the tears drain from this side into that side. So these are a few special considerations that we rarely come across, but I wanted to discuss this because these are like gray zones. You don't know what to do, but you have to take the best call in the interest of the patient. Thank you so much.
Thank you, Dr. Sonam, for summing up CNLDO in such a beautiful manner with such great pictures as well.
Sorry for overshooting. Thank you.